Guys, this is the audio recording for passive review and learning for anatomy. Section is thorax. Enjoy. The aorticopulmonary septum functions to divide the truncus arteriosus and bulbus cordis into the aorta and pulmonary trunk. The septum secundum forms an incomplete separation between the two atria. The septum premium divides the atrium into right and left halves. The bulbar septum is derived from the bulbus cordis and will give rise to the interventricular septum inferior to the aorticopulmonary septum, eventually fusing with it. The endocardial cushions play a role in the division of the AV canal into the right and left halves by causing the AV cushions to approach each other. Laryngeal atresia, congenital high airway obstruction syndrome, is a rare obstruction of the upper fetal airway. VSDs account for 25% of congenital heart defects. The most common of these are defects in the membranous portion of the interventricular septum, membranous VSDs. Transposition of the great arteries. Oxygenated blood travels from the left ventricle into the pulmonary trunk, where it will eventually reach the lungs. Tetralogy of Fallot is characterized by 4 cardiac defects: pulmonary stenosis, VSD, overriding aorta, and these in turn lead to right ventricular hypertrophy. And ASD is characterized by the communication between the two atria. In the case of transposition of great vessels, the aorta rises from the right ventricle and the pulmonary trunk arises from the left ventricle. Superior malalignment of the subpulmonary infundibulum causes stenosis of the pulmonary trunk. This leads to the 4 symptoms mentioned and is known as a tetralogy of Fallot. The murmur at S1 localizes the defect at an atrioventricular valve. An ASD causes a diastolic murmur in the tricuspid valve, whereas a VSD would cause a pansystolic murmur. Transposition of the great arteries and aortic stenosis will cause a murmur at S1, and a tetralogy of Fallot does not cause a murmur at S1 or S2. Down syndrome, more properly called trisomy 21, is associated with a cardiovascular abnormality such as arrhythmias and atrial and VSDs. Tetralogy of Fallot and truncus arteriosus are associated with DeGeorge syndrome, 22q11. Transposition of great arteries is associated with maternal diabetes. ASDs and VSDs are present in individuals with Down syndrome. Coarctation of the aorta is related to Turner syndrome. Marfan syndrome is present in individuals with aortic atresia. The ductus arteriosus is an embryologic structure that acts as a communication between the pulmonary trunk and the aorta. An ASD is a communication between the right and left atria. In the formation of the partition between the two atria, the opening in the foramen secundum, also known as the foramen ovale, typically closes at birth. If it remains patent, an ASD will result. Type 2 alveolar cells are the only cells that produce surfactant. An absence of musculature in one half of the diaphragm causes it to protrude into the thoracic cavity, forming a pouch into which the abdominal viscera protrude. The tracheoesophageal septum is a primordial structure that separates the trachea from the esophagus. If the structure fails to develop, a tracheoesophageal fistula will result, in which event the two structures will not separate completely. When the infant attempts to swallow milk, it spills into the esophageal pouch and is regurgitated. The child becomes cyanotic because an insufficient amount of oxygen is reaching the lungs as a result of the malformed trachea. Polyhydramnios is an excess of amniotic fluid, often associated with esophageal atresia or a tracheoesophageal fistula. The abnormality affects fetal ability to swallow a normal amount of amniotic fluid, therefore excess fluid remains in the amniotic sac. A congenital Heart defects are common problems that can be caused by teratogens, such as the rubella virus or a single gene factors or chromosomal abnormalities. Sinus venous ASDs occur close to the entry of the superior vena cava in the superior portion of the interatrial septum. Ostium secundum ASDs are located near the fossa ovale and encompass both septum primum and septum secundum defects. Ectopia cordis is a condition in which the heart is located abnormally outside the thoracic cavity, commonly resulting from a failure of fusion of the lateral folds in forming the thoracic wall. The right horn of the sinus venosus has two divisions. One develops into the sinus venerum, the smooth inferior aspect of the right atrial wall. The other half develops into the pulmonary veins. The septum transversum is a thickened layer of mesoderm that gives origin to the central tendon of the diaphragm. The fourth aortic arch develops into the aortic arch on the left side and the brachiocephalic and subclavian arteries on the right side of the embryo. Improper development of the arch of the aorta will cause an increased pressure in the subclavian artery and subsequently the brachial artery. The left sixth aortic arch is responsible for the development of both the pulmonary arteries and the ductus arteriosus. With the regression of the ductus arteriosus, a patent connection remains between aorta and the pulmonary trunk. The ductus arteriosus often reaches functional closure within 24 hours after birth, whereas anatomic closure and subsequent formation of the ligamentum arteriosum. With the PDA, an abnormal connection persists between the aorta and the pulmonary trunk. Blood leaving the left ventricle of the heart and into the aorta is reshunted back into the left pulmonary artery. This is responsible for the murmur heard during auscultation of the heart. A common truncus arteriosus results from failure of separation of the pulmonary trunk and aorta. Without proper perfusion of the child by oxygenated blood, severe cyanosis will result. The pleuroperitoneal membrane forms the posterolateral aspect of the diaphragm. A defect in this membrane will allow for communication between the upper left abdominal cavity and the thoracic cavity and could result in a congenital diaphragmatic hernia. The septum transversum provides origin to the central tendon of the diaphragm, but is not involved in herniation of the intestines. When closing a VSD, it is important not to suture over the right bundle branch because it carries the stimulating impulse from the atrioventricular node to the apex of the heart through the right bundle of His. Esophageal atresia is often the result of an incomplete division of the tracheoesophageal septum, thus causing an absence of or blinding ending of the esophagus. In tracheotomy, an incision is made at the level of the sixth cervical vertebra, near the cricoid cartilage. The left brachiocephalic vein passes across the trachea immediately anterior to the brachiocephalic trunk. This vein is the most superficial structure and thus the most likely to be damaged. The phrenic nerve has a path between the anterior medial aspect of the lung and the mediastinum. Along the path of the nerve, it courses anterior to the hilum of the lung. The vagus nerves run posterior to the heart as they give off branches to the cardiac plexus upon the trachea near the carina. The recurrent laryngeal nerves arise from the vagus nerves before the vagus nerves pass behind the hilum of the lungs. The left recurrent laryngeal nerve passes beneath the ligamentum arteriosum and then loops superiorly toward the tracheoesophageal groove, medial to the arch of the aorta. During mastectomy procedures, 3 superficial nerves are susceptible to ligation or laceration: the long thoracic nerve, the intercostal brachial nerve, and the thoracodorsal nerve. In the event of injury to the long thoracic nerve, the patient complains of an inability to fully abduct the humerus above the horizontal. The dorsal root ganglia contain nerve cell bodies for general somatic afferent and general visceral afferent neuronal processes. The lateral horns or intermediolateral cell columns contain the cell bodies of preganglionic neurons of the sympathetic system. The cardiopulmonary, splanchnic, or thoracic visceral nerves are responsible for carrying the cardiac sympathetic efferent fibers from the sympathetic ganglia to the thoracic viscera, and the afferent fibers for pain from these organs. The vagus nerve is responsible for carrying the parasympathetic fibers. The vagus nerve is the only nerve responsible for parasympathetic innervation of the lungs. There is close proximity between the aortopulmonary window and the left recurrent laryngeal nerve. A mass within or adjacent to this window is thus likely to compress the left recurrent laryngeal nerve, resulting in the hoarseness of the patient. The intercostobrachial nerve is responsible for innervation of the skin on the medial surface of the arm. The ulnar nerve is responsible for cutaneous sensation on the medial aspect of the hand, and the axillary nerve innervates the lateral aspect of the shoulder. Pericarditis is an inflammation of the pericardium and often causes pericardial friction rub, with the surface of the pericardium becoming gradually coarser. The intercostobrachial nerve is a lateral cutaneous branch of the second intercostal nerve. It serves the cutaneous function both in the thoracic wall and the medial aspect of the arm. The phrenic nerve arises from the spinal nerves C3 to C5 and innervates the diaphragm. General visceral afferent are nerve fibers that carry sensation from organs. These fibers get mixed with general somatic afferents and the dorsal roots. This is the phenomenon of referred pain. The anterior and lateral cutaneous branches of the fourth intercostal nerves provides the sensory and sympathetic supply of the areola and nipples. The left recurrent laryngeal nerve passes superiorly in the tracheoesophageal groove after looping around the aorta. With a dilated left atrium, the most probable structure being compressed is the esophagus. The esophageal hiatus in the diaphragm is one of the four openings associated with the diaphragm. It is located at the level of T10 and allows esophagus to pass through the thoracic cavity into the abdominal cavity. The apex of the heart is located in the left fifth intercostal space, about 3.5 inches to the left of the sternum. When this area of the heart is palpated, any pulsations would be generated by throbbing of the apex of the heart against the thoracic wall. The right ventricle is located on the most anterior aspect of the heart. Thus, it is the most anterior portion of the heart within the thorax. The apex of the left ventricle is also located anteriorly, but it is located lateral to the sternum and occupies little area compared with the right ventricle. The left ventricle is positioned on the left lateral side and slightly posterior position in the thorax. The right atrium is located in the right lateral side of the heart. The anterior margin of the left atrium is positioned posteriorly in the thorax. The left fifth intercostal space just below the left nipple is typically the best location to listen to the mitral valve. The great cardiac vein, also called the anterior interventricular vein, takes a pathway initially besides the anterior interventricular coronary artery, left anterior descending LAD, in its course, finally terminating in the coronary sinus when it is joined by the oblique vein of Marshall of the left atrium. This vein must be protected when performing bypass procedures. The anterior interventricular artery supplies the right and left ventricles, and anterior 2/3 of the IV septum. The right marginal artery supplies the right ventricle and apex of the heart, therefore it does not supply the left ventricle. The left coronary circumflex artery supplies the left atrium and left ventricle. It courses posteriorly in or near to the coronary sulcus and supplies the posterior portion of the left ventricle and left atrium. The artery to the SA node is a branch of the right coronary artery and does not supply the left ventricle. The posterior interventricular artery arises from the right coronary artery in about 67% of the people. This is referred to as a right dominant pattern and supplies the posterior aspect of the both ventricles and posterior third of the interventricular septum. The anterior interventricular artery, LAD, arises from the left coronary artery. When the patient is left coronary artery dominant, if there is a 70 to 80% occlusion of the left coronary, there will be deficiencies in flow both in the anterior descending and circumflex coronary arteries. The mitral valve corresponds to the S1 heart sound produced during systole. The aortic and pulmonary valves correspond to S2 sound produced during diastole. The tricuspid valve also corresponds to the S1 heart sound. The interventricular septum is intimately involved in the tricuspid valve on the right side via the muscular connections to the septomarginal trabeculum moderator band to the anterior papillary muscle. Therefore, if the electrical system of the heart is disrupted, as with the myocardial infarction in the upper portion of the muscular septum, the innervation of the interventricular septum will be compromised, and the tricuspid valve will be directly affected. The pulmonary valve is associated with the S2 heart sound produced in diastole. A splitting in the S2 sound indicates that the aortic and pulmonary valves are not closing simultaneously and would correlate with a possible defect in the valve. The atrioventricular bundle of His is a collection of specialized cardiac muscle cells, Purkinje fibers, that carry electrical activity to the right and left bundle branches. The atrioventricular bundle of His is a strand of specialized cardiac muscle cells, Purkinje fibers, that arises from the atrioventricular node and passes through the right fibrous trigone. The sternocostal surface of the heart consists mostly of the right ventricle. Therefore, an anterior injury to the thorax would most likely first affect the right ventricle because it is adjacent to the deep surface of the sternum. The interventricular septum and the anterior ventricular wall are mostly supplied by the proximal portion of the left anterior interventricular artery, the LAD. A left coronary dominant circulation means, put simply, that the left coronary artery, LCA, provides the posterior interventricular artery as a terminal branch of coronary circumflex. The posterior aspect of the heart is composed primarily of the left ventricle and is supplied by the posterior interventricular branch. The eustachian valve is an embryologic remnant of the valve of the inferior vena cava and is not a functional valve. The crista terminalis is a muscular ridge that runs from the opening of the superior vena cava to the inferior vena cava. This ridge provides the path taken by the posterior internodal pathway between the SA and atrioventricular nodes. During pericardiocentesis, the needle is inserted below the xiphoid process or in the left fifth intercostal space in the midclavicular line. The anterior interventricular left anterior descending artery lies anteriorly and to the left and descends vertically to the left toward the apex. It can be more easily injured by a transverse incision of the pericardium, which would cross perpendicular to this artery. A finger passing through the transverse pericardial sinus passes directly behind the two great arteries exiting the heart, allowing the surgeon to rather easily place a vascular clamp upon pulmonary trunk and the ascending aorta. The middle cardiac veins run parallel with the posterior interventricular posterior descending artery and drains directly into the coronary sinus. The left coronary artery bifurcates into the anterior interventricular artery, the left anterior descending or LAD, and the coronary circumflex branch. The circumflex branch gives off the left marginal branch, which supplies the lateral wall obtuse margin of the left ventricle. The anterior part of the interventricular septum is supplied by the LAD. The atrioventricular node is most commonly supplied by a branch of the right coronary artery. The first heart sound is caused by the closure of the tricuspid and mitral valves. The second heart sound is caused by the closure of the aortic and pulmonary valves. The second heart sound is caused by the closure of the aortic and pulmonary valves. The first sound by the heart is caused by the closure of the tricuspid and mitral valves. The superior vena cava empties into the right atrium on the superior aspect of the heart. It is not directly palpable from the oblique sinus. Cardiac tamponade is characterized by hypotension, tachycardia, muffled heart sounds, and jugular vein distension. Right coronary dominant circulation refers simply to the fact that the right coronary artery provides origin for the posterior interventricular, posterior descending coronary artery. The chordae tendineae are fibrous cords that connect papillary muscles to valve leaflets. The restraint provided by these cords on the valve leaflets, along with the contraction of the papillary muscles, prevents the prolapse of the mitral valve cusps into the left atrium. The correct path that leads to the right ventricle for the lead of the pacemaker is the brachiocephalic vein, superior vena cava, right atrium, tricuspid valve, and right ventricle. Mitral stenosis leads to the left atrial dilation, which can exert a compressive effect on the esophagus. The SA node, the primary pacemaker of the heart, is a mass of specialized cardiac cells within the myocardium, at the upper end of the crista terminalis, near the opening of the superior vena cava into the right atrium. The tricuspid valve is the atrioventricular valve located between the right atrium and right ventricle. An incompetent valve would allow blood to regurgitate into the right atrium during systole and subsequently raise pressure in the venous system, increasing the capillary pressure and causing edema. To avoid damaging lungs, a chest tube should be placed below the level of the lungs in the costodiaphragmatic recess. Such a point of entrance for the tube would be the 8th or 9th intercostal space. The parietal pleura is innervated by the intercostal nerves and is very sensitive to pain, in this case being somatic innervation. The right main bronchus is shorter and wider and more vertical primary bronchus. Therefore, this is most often location that foreign objects will likely be lodged. Contraction of the diaphragm descends or pulls the dome inferiorly, increasing the vertical dimension of the thorax. This is the most important factor in the inspiration for decreasing intrathoracic pressure, thereby increasing the internal pulmonary volume. The horizontal fissure of the right lung is a fissure separating the superior lobe from the middle lobe. Inflammatory breast cancer. The common symptoms include inversion of the nipple and dimpling of the overlying skin, changes that are due to the retraction of the suspensory ligaments of Cooper. The inferior tracheobronchial nodes are also known as the carinal nodes and are located on the inferior aspect of the carina, the site of bifurcation of the trachea. The superior lobar bronchus is one of the divisions of the right main bronchus. The bronchus branches into apical, anterior, and posterior tertiary bronchi. Lymphatic drainage of the breast is typically to the axillary nodes, more specifically to the anterior pectoral nodes. Lymphatic vessels from the pectoral nodes continue into the central axillary nodes. Increased arterial pressure in the upper limbs as demonstrated in the brachial artery and decreased pressure in the lower limbs as demonstrated in the femoral artery are common symptoms of coarctation of the aorta. Coarctation of the aorta. This condition occurs when the aorta is abnormally constricted. One of the cardinal radiographic signs is characteristic rib notching. The long thoracic nerve arises from the C5, C6, and C7 ventral rami and innervates the serratus anterior muscle. Injury of this muscle Injury of this nerve will result in the characteristic winged scapula. The superior margin of the manubrium is characterized by the jugular notch. The thoracic duct is important in lymph drainage of the entire body with the exception of the upper right quadrant. The thoracic duct ascends between the aorta and azygous vein behind the esophagus. The anterior intercostal arteries anastomose with the posterior intercostal arteries. Ligation of the anterior arteries would not affect the supply of the intercostal spaces because the posterior arteries would provide collateral arterial supply. The thymus lies in the superior mediastinum and extends upward into the neck, especially in the young. The parietal pleura can be divided regionally into costal, diaphragmatic, mediastinal, and cervical portions, depending upon local topographic relations. The right primary bronchus is shorter, wider, and more vertical than the left main bronchus. When a foreign body is aspirated, it is more likely to enter in the right main bronchus, although in some cases, the foreign body enters the left bronchus. The normal position of the heart. It has the right border of the heart formed by the superior vena cava, right atrium, and inferior vena cava. The left border is formed by the aortic arch superiorly, left pulmonary artery, left auricle, left ventricle, and the apex of the heart inferiorlaterally. When multiple rib fractures produce a flail segment of the thoracic wall, paradoxical motion of the flail segment is commonly experienced upon deep inspiration. That is, the flail area is sucked in rather than expanding outward with inspiration, and the reverse movement occurs in expiration. The subclavian artery lies directly posterior to the subclavian vein. Therefore, it is a structure that would be most vulnerable to damage when placing a central venous line in the subclavian vein. Lymph from the lower third of the esophagus drains into the posterior mediastinal and left gastric lymph nodes. The middle third of the esophagus drains into posterior and superior mediastinal lymph nodes. The upper third of the esophagus drains into the deep cervical nodes. Lymph from the right primary bronchus would drain first into the inferior tracheobronchial nodes. The artery of Adamkiewicz, or the great radicular artery, is an important artery that provides oxygenated blood to the lower portion of the spinal cord, specifically the anterior cord where lower motor neurons are located, inferior to the vertebral level of the origin of the artery, and provides collateral anastomosis with the anterior spinal artery. Care should be taken during surgery to prevent damage to this artery, as this can lead to paraplegia and alteration of functions of the pelvic organs. A left tracheal deviation with an enlarged thyroid gland will most likely compress the left brachiocephalic vein. The carina is at the level of T4 to T5, plane associated with the sternal angle of Lewis. This landmark is commonly used to guide the placement of central venous line. Gynecomastia is the abnormal growth of mammary glands in males. Polythelia refers to supernumerary or extra nipples. Polymastia refers to supernumerary breasts. A tension pneumothorax is caused by injury to the lung, leading to air in the pleural cavity. The site of the wound acts as one-way valve, allowing air to enter the pleural cavity but not to leave the cavity. The lack of negative pressure in the pleural cavity causes lung to collapse. Chylothorax is usually caused by injury to the thoracic duct. The thoracic duct enters the venous system at the junction of the left internal jugular vein and the left subclavian vein, where they form the left brachiocephalic vein. The inferior vena cava quite likely undergoes compression by the growing fetus when the mother is in the supine position. In this case, the compression led to reduced blood flow through the heart, with the resultant drop in blood pressure. Crackling noises in the lungs due to buildup of fluid are referred to as rales. The fluid usually migrates to the inferior portion of the lung due to the effects of gravity. Auscultation over the sixth intercostal space at the mid-axillary line would be associated with the lower lobe of the right lung. Pericardiocentesis is usually performed through the infrasternal angle, with the needle passing up through the diaphragm to the fibrous pericardium. The diaphragmatic surface of the heart is largely composed of the right ventricle and would therefore be entered if a needle is inserted too far. The pain experienced by the patient travels with the sympathetic innervation of the heart, derived from the spinal nerve levels T1 to T4. The pain fibers leave the heart and the cardiac plexuses via the cardiopulmonary nerves. Subsequently, the pain fibers pass through the sympathetic chain, enter the spinal nerve, and pass into the dorsal roots of the spinal nerves. The cell bodies of the pain fibers are located in the dorsal root ganglia of the spinal nerves from the T1 to T4. The bucket handle motion of the ribs affects the transverse diameter of the thorax. Inspiration would increase the transverse diameter, whereas expiration decreases the transverse diameter. The antero-posterior diameter of the thorax is increased and decreased by the pump handle movements of the ribs and sternum. Bronchial constriction is induced by the parasympathetic innervation of the airways. This is supplied by the vagus nerves, which could be blocked to result in relaxation of the airways. The phrenic nerve provides motor and sensory innervation to the diaphragm. The location where one is least likely to damage important structure by making an incision or pushing a chest tube into the thorax is over the upper border of the rib. At the inferior border of each rib, one will encounter intercostal vein, artery, and nerve, in that order, van structures. Entrance through the middle of the intercostal space does not eliminate the heightened possibility of piercing important structure. Cardiac tamponade is a condition in which fluid accumulates in the pericardial cavity. It can result from pericardial effusion or from leakage of blood from the heart or proximal portions of the great vessels. The increased pressure within the pericardial sac leads to the decreased cardiac filling during diastole and therefore reduced systolic blood pressure. Because of the reduced pumping capacity of the heart, there is an increased pressure in the venous system, leading to the distension of the jugular venous system. The S2 heart sound refers to the second dub heart sound. This sound is produced by the closure of the aortic and pulmonary semilunar valves. The closure of the mitral and bicuspid and tricuspid valves produce the first S1 lub heart sound. Flail chest is characterized by paradoxical breathing movements caused by multiple rib fractures. An aneurysm of the aortic arch could impinge upon the phrenic nerve, causing referral of pain to the left shoulder. This referral occurs because the root levels of the phrenic nerve are C3 to C5, nerve levels that are also distributed to the skin over the shoulder region. The SA node functions as the primary intrinsic pacemaker of the heart, setting the cardiac rhythm. An artificial pacemaker assists in producing a normal rhythm when the SA node is not functioning normally. Postganglionic parasympathetic fibers are involved in the constriction of smooth muscle in the tracheoesophageal tree. Sympathetic fibers cause dilation of the structure. Dextrocardia is a condition that results from a bending of the heart tube to the left instead of to the right. The esophagus typically has 4 constrictions. In the thorax, the esophagus is compressed by the arch of the aorta, the left principal bronchus, and the diaphragm. The cricopharyngeal constriction is in the neck. The dermatome that encompasses the nipple is supplied by the spinal nerve T4. Due to rib fracture, the intercostal vessels are damaged. Parietal pleural is torn. and blood flows into the pleural space. The loss of negative pressure within the pleural cavity results in collapse of the lung. Meiosis, partial ptosis, and anhidrosis are a clinically important constellation of symptoms, possibly indicating Horner's syndrome. Horner's syndrome is a lesion of the cervical sympathetic chain and sympathetic chain ganglia, and is often a result of a Pancoast tumor, also known as a superior pulmonary sulcus tumor of the apex of the lung. The esophagus lies posterior to the heart. Of the four chambers in the heart, the left atrium lies most posteriorly, just anterior to the esophagus when the heart is in its normal position in the mediastinum. The inferior vena cava runs on the right side within the thoracic cavity and empties its contents into the right atrium. Artificial pacemakers are commonly used to treat patients who have weak or failing heart conduction systems. The electrode or tip of the pacemaker is threaded through the subclavian vein to the superior vena cava into the right atrium, and then the right ventricle, where it is used to stimulate the Purkinje fibers to result in ventricular contraction. Cardiac hypertrophy is a compensatory mechanism of the myocardium in response to increasing demands on the heart due to ischemia, incompetent valves, or hypertension. The increased size of the heart muscle would most likely compress the esophagus, and due to the incompetent mitral valve, a backflow of blood into the left atrium can cause a left atrial dilation. The left atrium lies just anteriorly to the esophagus in the mediastinum. Tension pneumothorax is a progressive accumulation of air in the pleural cavity that is trapped during inspiration. The resulting increase of pressure diminishes the negative pressure required to maintain an inflated lung, resulting in a collapsed lung as seen on the radiograph. The right upper lobe extends from the apex of the lung above the clavicle to the fourth rib. In many people, the anterior interventricular branch of the left coronary artery gives rise to a lateral diagonal branch that descends on the anterior surface of the heart. Blockage of cutaneous lymphatic vessels results in edema of the skin surrounding the hair follicles, leading to an appearance like an orange peel, peau d'orange. Shortening of the suspensory ligaments leads to dimpling of the overlying skin. The patient is suffering cardiac tamponade, is filling of the pericardial cavity with fluid. The classic signs of this tamponade are referred to as Beck's triad. This trio, by definition, includes a small heart from a compression of the heart by the fluid-filled pericardial sac, and a quiet heart because the tamponade muffles the cardiac sounds. Decreased pulse pressure resulting from the reduced difference between systolic and diastolic pressure because the tamponade restricts the ability of the heart to fill in diastole. And increased central venous pressure because venous blood cannot enter the compressed heart. Myelin degeneration of the phrenic nerves, as can occur in Guillain-Barré, results in loss of the phrenic nerve function and paralysis of the diaphragm. Diaphragmatic paralysis is predictable with lack of movement of the abdominal wall in respiratory efforts. The loss of myelin from the preganglionic, normally myelinated, sympathetic fibers from T1 to T4 results in interruption in their transmission of electrical stimulating impulses, and therefore reduction of positive inotropic and chronotropic stimulation of the heart. Inotropic is force increasing, and chronotropic is rate increasing. The mitral valve is best visualized by TEE because the transducer within the esophagus is directly posterior to the left atrium. Pneumomediastinum describes the presence of air in the mediastinum and may arise from a wide range of pathological conditions. A tracheoesophageal fistula, TEF, is an abnormal communication between trachea and esophagus, This is a congenital anomaly that results from the incomplete fusion of the tracheoesophageal folds that separate the trachea from the esophagus embryologically. By placing a chest tube just superior to the upper border of the rib, the important neurovascular bundle is avoided. The bundle consists of intercostal vein, artery, and nerve running through the superior portion of the intercostal space. Postductal coarctation. This type of coarctation is the most common type found in adults. It is associated with the typical symptoms of notching of the ribs, hypertension in the upper limb, and weak pulses in the lower limbs. Congenital diaphragmatic hernia is a relatively common congenital anomaly. It is most often seen as posterolateral defect in the diaphragm, resulting from the defective formation or fusion of the pleuroperitoneal membranes with the other three embryological parts of the diaphragm. The sympathetic system innervates the sweat glands located in the skin and subcutaneous tissue. The postganglionic cell bodies are located in the sympathetic chain from T1 to T4, which corresponds to the chest wall. The postganglionic fibers leave the sympathetic chain via the gray ramus communicans to enter the T1 to T4 spinal nerves in order to get to their target. The lateral quadrants of the breast drain into the anterior axillary pectoral, which is approximately 75% of the lymphatic drainage. The medial quadrants drain into the parasternal nodes with some drainage to the parasternal nodes of the opposite breast. There is also a small amount of drainage of the inferior part of the breast into lymph nodes of the anterior abdominal wall. The central and apical axillary nodes receive lymphatic from the pectoral, lateral, and posterior axillary nodes. Pulmonary stenosis of the pulmonary valve results in a systolic murmur that can be auscultated at the left second intercostal space. The intercostal brachial nerve is the lateral cutaneous branch of the second intercostal nerve and is responsible for the sensation to the medial side of the arm. The suspensory ligaments of Cooper are well-defined condensations of connective tissue that run from the clavicle to the dermis of the skin overlying the breast. They support and suspend the breast from the chest wall. Carcinoma of the breast produces tension of these ligaments and causes dimpling of the breast. The right coronary artery supplies the right ventricle, which lies immediately posterior to the sternum. The circumflex artery supplies the left atrium. The anterior interventricular artery supplies the left ventricle and the anterior 2/3 of the interventricular septum. The CT scan shows an aneurysm of the arch of the aorta. The left recurrent laryngeal artery loops around the arch of the aorta before traveling in the tracheoesophageal groove to supply the larynx. The vagus nerve travels anterior to the aorta and will not be compressed. The phrenic nerve travels anterior to the hilum of the lung and will not be affected in the case. The right recurrent laryngeal nerve loops around the right subclavian artery. The greater splanchnic nerve originates in the thorax from the sympathetic chain at the levels of T5 to T9 and innervates abdominal structures. During development, the right subclavian artery forms from the 4th pharyngeal arch and 7th intersegmental arteries. During embryonic development, the left dorsal aorta gives rise to the thoracic aorta. The aortic arch is formed by the aortic sac and the 4th pharyngeal artery. The 3rd pharyngeal artery will give rise to the common carotid artery. The 5th pharyngeal artery will disappear bilaterally, and the 6th will form the ductus arteriosus on the left and part of the pulmonary trunk. The septum secundum develops from the dorsal endocardial cushion and the wall of the primitive atria ventrally. It overgrows the septum primum which becomes a one-way valve during intrauterine development. The foramen primum is the space between the endocardial cushion and the developing septum primum. The truncus arteriosus will give rise to the ascending aorta and a pulmonary trunk. The bulbus cordis will give rise to the smooth parts, arterial outflow of both the left and right ventricles. The phrenic nerve passes anterior to the hilum of the lung on both the left and right sides and wraps around the hilar structures inferiorly. The phrenic nerve innervates the diaphragm and, if damaged, causes dyspnea. The vagus nerve passes along the esophagus as the left and right trunks and is posterior to the hilum on both sides. The left atrium lies directly anterior to the esophagus and compresses it when enlarged, resulting in difficulty swallowing. Nausea and vomiting may be present, but is a symptom of a wide array of dysfunctions and are not a direct result of the enlarged atrium. The apex of the heart is typically visualized and palpated in the fifth intercostal space of the midclavicular line. This is termed the apex beat and is the result of blood being forced against it during atrial contraction. The great cardiac vein accompanies the anterior interventricular artery, and the middle accompanies the posterior interventricular artery. The small cardiac vein accompanies the right coronary artery as it wraps around the right coronary sulcus. Thoracocentesis is a procedure whereby a needle is inserted into the pleural space to evacuate air or fluid that has become trapped. The esophageal hiatus creates a physiological sphincter during diaphragmatic contraction. As the esophagogastric junction does not have a valve either anatomically or physiologically, this would be the last point of resistance. The question of dominance is determined by where the posterior interventricular artery arises. If it arises from the right coronary, it is a right dominant heart. If from the circumflex of the left coronary, it is left dominant. Murmurs of the tricuspid valve can be best auscultated in the fourth intercostal space at the left border of the sternum. The fifth intercostal space, midclavicular line, is the best site to auscultate the mitral valve. Second and third intercostal spaces on the right side of the sternum are areas to listen to for the aortic valve. Signs of cardiac tamponade, known as Beck's triad, includes hypotension, muffled or absent heart sounds, and jugular venous distension. As a result, pericardiocentesis procedure should be performed. The SA node receives information from the sympathetic preganglionic fibers T1 to T4 to increase the heart rate. If these fibers are damaged, the preganglionic vagal fibers from the cardiac plexus are unopposed and will slow down the heart rate. The thoracic duct originates from the cisterna chyli in the abdomen and ascends through the aortic hiatus in the diaphragm. It ascends in the posterior mediastinum among the thoracic aorta on its left, the azygous vein on its right, and the esophagus anteriorly. It ascends in the posterior mediastinum among the thoracic aorta on its left, the azygous vein on its right, the esophagus anteriorly, and the vertebral bodies posteriorly. The major structures in the superior mediastinum from anterior to posterior are thymus, veins, arteries, airway, alimentary tract, and lymphatic trunks. A tension pneumothorax occurs when intrapleural air accumulates progressively, exerting positive pressure on mediastinal and intrathoracic structures. It is a life-threatening occurrence requiring rapid recognition and treatment if cardiac arrest is to be avoided. Pericardial effusion is an abnormal accumulation of fluid in the pericardial cavity. With ectopia cordis, a rare condition, the heart is in an abnormal location. In the thoracic form of the ectopia cordis, the heart is partly or completely exposed to the surface of the thorax. There are four clinically significant types of ASD: ostium secundum defect, endocardial cushion defect with ostium primum defect, sinus venosus defect, and common atrium. The first two types of ASD are relatively common. Endocardial cushion defects with ostium primum occur in approximately 20% of persons with trisomy 21 Down syndrome. Otherwise, it is a relatively uncommon cardiac defect. VSDs are the most common type of coronary artery disease, accounting for approximately 25% of heart defects. A membranous VSD is the most common type, but it may occur at any part of the interventricular septum. With isolated dextrocardia, the abnormal position of the heart is not accompanied by displacement of other viscera. This defect is usually complicated by severe cardiac anomalies, single ventricle, and transportation of the great vessels. Tetralogy of Fallot consists of four cardiac defects: pulmonary artery stenosis, VSD, dextroposition of aorta, overriding or straddling aorta, and right ventricular hypertrophy. Patent ductus arteriosus (PDA), a common birth defect, is 2 to 3 times more common in females than males. If it remains patent, aortic blood is shunted into the pulmonary trunk. Congenital diaphragmatic hernia is usually unilateral and results from defective formation and or fusion of the pleuroperitoneal membranes with the other three parts of the diaphragm. This results in a large opening in the posterolateral region of the diaphragm. As a result, the peritoneal and pleural cavity are continuous with one another. As a result, the peritoneal and pleural cavity are continuous with one another along the posterior body wall. A tension pneumothorax occurs when intrapleural air accumulates progressively, exerting a positive pressure on mediastinal structures and leading to mediastinal shift to the opposite side. It is a life-threatening occurrence requiring rapid recognition and treatment if cardiorespiratory arrest is to be avoided. Pleuritic pain is due to the inflammation of the parietal pleura, which is mainly supplied by the intercostal nerves. The phrenic nerve only supplies the central and diaphragmatic parts of the visceral pleura, which are typically affected and not amenable to nerve blocks. Due to the long looping course of the left recurrent laryngeal nerve and its location in the superior mediastinum, it is more easily damaged during the thoracoscopic procedures than the other nerves, which are more posterior and protected from introduction of the thoracoscope. Any pneumothorax may cause hyperresonance to percussion, decreased breath sounds, and reduced vascular markings, but tracheal deviation to the opposite side accompanied by distended jugular veins can only be caused by a tension pneumothorax. Cardiac tamponade will cause muffled heart sounds, decreased blood pressure, and distended jugular veins. The right and left main coronary arteries arise directly from the root of the aorta. The left main coronary artery divides the anterior interventricular left anterior descending (LID) and circumflex coronary artery. The anterior interventricular artery supplies the anterior 2/3 of the interventricular septum through septal perforating branches and the anterior wall of the left ventricle with diagonal branches. The circumflex coronary artery supplies most of the anterior and left lateral surfaces of the heart via obtuse marginal branches. The right coronary artery gives rise to the artery to the SA node and artery to the AV node. It also gives rise to the coronal artery supplying the area of the subpulmonary infundibulum of the anterior ventricular wall to the acute marginal artery that supplies the lower portion of the anterior ventricular wall. In 85 to 90% of individuals, the right coronary artery gives rise to the posterior interventricular artery. The embryological basis of the combination of lesions is anterosuperior deviation of the developing outlet ventricular septum and hypertrophied septoparietal trabeculations. The deviation of the muscular outlet septum is also responsible for creating the malalignment type of ventricular septum defect and results in the aortic override. The main structure immediately posterior to the esophagus is the descending aorta, and the anterior to esophagus is the left atrium, which is adjacent to the esophagus at this point. The left atrium forms the majority of the posterior surface of the heart and resides adjacent to the esophagus. Enlargement of the left atrium can compress the esophagus and cause dysphagia. The defects in the diaphragm are at T8 for IVC and phrenic nerve, T10 for esophagus, T12 for aorta and thoracic duct. Pneumothorax will cause hyperresonance to percussion, decreased breath sounds, reduced vascular markings, tracheal deviation to the opposite side, and distended jugular veins. Deep vein thrombosis may lead to pulmonary embolus, which can cause shortness of breath and even death, but not Beck's triad. Hemothorax presents with dullness to percussion and long field opacification. The pulmonic valve is auscultated at the left parasternal area and the second intercostal space, whereas the aortic valve is best heard at the right parasternal area in the second intercostal space. The mitral bicuspid valve is auscultated at the apex of the heart, which is typically the fourth or fifth intercostal space at the midclavicular line, to the right of the sternum. The tricuspid valve is auscultated at the fourth intercostal space, right parasternal border. Since the sternal angle of Louis is in the transverse plane the best plane to view both the anterior and posterior mediastinum as well as superior mediastinal structures would be the lateral view. Anteroposterior or posteroanterior would make it difficult separating anterior and posterior structures. Since the sternal angle of Louis is in the axial plane, an axial cut may miss the level completely. The order traverse is skin, external intercostal muscles, internal intercostal muscles, innermost intercostal muscle, and parietal pleura. The chest tube should not traverse the visceral pleura because that could cause a pneumothorax when it is removed.